In continuation to our series of continuous nephrology education, today we are going to discuss the medical aspects of nephrolithiasis. The agenda will include some historical backgrounds about the stone and the pathophysiology, and I'll end with case and questions to cover the majority of the medical aspects of urinary stones. To start with the history, in the ancient Egyptian era, there was no surgical treatment recommendation. They treated the stones with just a bill of wheat, yellow ochre, water taken for 4 days. So this is just a plant and water. And this slide showed the oldest urinary bladder calculus detected at Alamara in 1901. And this is one of the oldest stones detected in the human history. Hippocrates later stated that he didn't like surgery, and he said, I will not use the knife, and the Hindu treated stones with vegetarian diet and exercise recommendation. To start with the demographic characteristics of stones and the prevalence of stone, this slide showed the data came from the United States of America, and this data of 5 years admission, 20% of all admission to the hospitals from 1998 to 2003. And as you see, more than 181 million patients. Among these patients, 898,000 had stones. So the percentage of stone admission is 0.5%. And based on CT scan examination of the patient to detect urinary abnormalities, stones were present in 11%, as the study showed. And even from the pediatric follow-up, as you see, the stone is increasing in generally and more in the female, as you see in this slide. One of the important points is the correlations and the relations of renal stones and chronic kidney disease. Renal stones can lead to chronic kidney disease by many mechanisms, including obstruction, infections, and even the use of extracorporeal shockwave lithotripsy may lead to some injury. So I am not astonished that I find the stone formers, in stone former chronic kidney disease is more prevalent than patients without stones. But it is funny that patients with chronic kidney disease are less likely to form stones, because in chronic kidney disease there is less excretion of calcium. If the patient is symptomatic, even if the patient is potentially donor for kidney donation, and he has symptoms, the more the presence of the symptoms, the more the likelihood of development of albuminuria. So we should discriminate between presence of stones and symptomatic stones. Stones can constitute, as reported here, 3.2% of all patients on dialysis and transplantation. The original kidney disease is related to stone formations. And these are the different types of stone to end-stage kidney disease. The leading cause is strophyte stone, infection-related stones, followed by calcium stones, uric acid nephrolithiasis, and hereditary diseases. We shouldn't consider stones as merely presence of stones in the kidney or ureters or bladder, but it may be associated with very important comorbidities like acute myocardial infarction. And this study showed that patients with stones are more likely to have acute myocardial infarction. You can say because of comorbidities in the two diseases, the same comorbidity in stones are the same comorbidities associated with ischemic heart disease, but this analysis showed that the presence of stone is independently associated with ischemic heart disease and acute myocardial. This figure showed the different types of stone formations, and stone formers included calcium oxalate stones, calcium oxalate plus phosphate or oxalate alone, or strophyte stone phosphate, and you can see the distribution percentage for each type of stone in these populations. The etiology is either hypercalciuria, hyperoxaluria, hypocitraturia, hyperuricosuria, medications, renal tubular acidosis, or anatomic abnormalities in urinary tract. So all these factors can contribute to the stone formations. If I start with hypercalciuria, I divide hypercalciuria into hypercalciuria without hypercalcemia. This is idiopathic hypercalciuria, or hypercalciuria with different causes of hypercalcemia, as shown in this slide, such as causes related to malignancy, primary hyperparathyroidism, granulomatous disease, immobilizations, and hyperthyroidism. Regarding hyperoxaluria, maybe dietary, maybe diets, high vitamin C intake, enteric oxaluria, or malabsorption, because in malabsorption, the free fatty acid take calcium, so oxalate is ready for absorption, leading to stone formation. Hypocitraturia in cases of hypokalemia, metabolic acidosis, etc. All these causes can lead to stone formation. Uric acid stone is more frequent with patients consuming a high animal protein diet, with diarrhea, with low urine volume, and with hyperuricosauria. And the factors associated with strovite infection stone formations are infections related to urease producing bacteria like Proteus, Haemophilus, Yersinia, Staph, Klebsiella, Serratia, Styrobacter, Uroplasma, and all these infections are associated with high urinary pH, leading to strovite stone formations. If I wanted to summarize how to deal and how to manage urinary stones, this includes the multidisciplinary team approach, and it depends upon meticulous history taking, thorough clinical examination, and laboratory evaluation plus radiological investigation. So if I take the urine analysis at the first step in my evaluation, urine pH is very important. Why? It may be high in strovite stones and the calcium phosphate stones, low in uric acid and the calcium oxalate. So if I have a patient with a stone formation and urine pH is acidic, one of the strategies of treatment is to alkaline urine, and vice versa. If it's alkaline, I shouldn't alkaline the urine. Specific gravity is very important because it may show indirect clue that the patient doesn't drink water well. If I find specific gravity high, this means and confirms inadequate fluid intake. If there is hematuria, this may be a symptom of stone passing or crystal formation. And the urine analysis may show this oxalates, stone, uric acid crystals, strovites, cystine crystals. All these crystals are very important while I am doing urine examination. I should search on the presence of all these crystals. Another important point, urine culture is important because it proves the type of infection that should be eradicated to decrease the incidence and formation of a stone. Regarding the blood investigation, it includes basic evaluations like serum electrolytes, sodium, potassium, chloride, and bicarbonate. All of these are important in basic investigation. Serum creatinine, serum calcium, serum phosphorus, and uric acid, serum PTH in the presence of high hypercalcemia and the low phosphorus. And so stone analysis, it is very important. As you see in this slide, these are the different type of stones and different architecture. Radiology of stone examination include plain X-ray of the abdomen that showed the presence of radio-oblique stones, as you see here, in the kidney and the bladder. And here is the horn stone and the bladder stone. And this is spiral CT, axial cut showing the presence of stone. And by the way, a spiral CT is a marvelous investigation because we don't inject contrast and give a good idea about the presence of a stone in all urinary tract, plus the presence of consequences of the presence of stone like obstruction. 24-hour urine should be done, especially in recurrent stone formation, and the data of normal urine should be the urine volume above 2 liters per day. Calcium in urine shouldn't exceed 300 milligram in males and 250 in females. Oxalate shouldn't exceed 40 milligram per day. Uric acid shouldn't exceed 750 in women and 800 milligram in men. The citrate should be above 320 because citrate is protector against stone formation, and this is more prevalent in women than men. Sodium should be less than 3,000 milligram. Phosphorus should be less than 1,100 milligram. And to be sure that the quantification of urine is accurate, urinary creatinine should be done to ensure the good urine output collection should be above 10 milligram per kg in women and 15 milligram per kg in men. Even while we are doing endoscopy for the urinary system, if we find Randall Blake like this may denote calcium oxalate deposition, and it starts here in the ascending limb of Henle and then increasing. And this is another type, and you see the papilla is completely different from the other type. This is calcium phosphate stone. If I'm dealing with calcium oxalate stone, it's better to alkalize urine, and here it is not recommended to alkalize urine. Regarding the treatment of stone clinic is very important, and there is what is known as stone clinic effect. This may be due to advice of water drinking or something like that. The main lines of treatment relies upon fluid intake, so we encourage the patient to drink a lot of water through the day to avoid the presence of concentrated urine, and so the patient should drink in the early morning and then drinking with the hour all over the day to avoid the concentrations, because the higher the concentration you allow, the higher the chance to form nidus for stone formation. The second point, we should avoid the excess salt intake, because sodium restriction leads to decreasing calcium excretion and decrease the chance of stone formation. Dietary protein restriction, especially the animal protein, because the higher the protein intake, the higher the tendency for acidosis, and the acidosis will lead to dissolution of the bones, leading to mobilization of calcium and hypercalciuria. So we should modest the protein intake in the diet. Regarding the calcium, we don't advise calcium restriction as was sought, because if you restrict the calcium, you will leave oxalate unbound, leading to more oxalate absorption, leading to more oxalate stone formation. So we don't advise calcium restriction. We should advise the daily intake of calcium regarding the age in men and women, and we don't advise calcium restriction. If calcium is indicated to be restricted, we should also restrict oxalate to avoid calcium oxalate stone formation. Another interesting study that was done in Salvador that discusses the issue of the value of the high urine output and its correlations with deterioration of kidney function. As you see here, this is the graph showing the rate of decline of glomerular filtration rate in this vertical axis, and the horizontal axis show the volume of urine per 24 hour. Here, the lower the urine output, the higher the decline of the GFR. If the urine output is below 1 liter per day, the decline of GFR is significantly higher than if the urine output exceeding 3 liters. So here, based on this, I know it is observational study and is not a randomized study, and so in general population, it is better to encourage modest water intake to allow urine output even above 2 liters, and this is a good point for the general population. But could we generalize this to patients with CKD? The answer is no, because patients in CKD cannot concentrate or dilute urine, so the more the water they intake, the more the retention of water, leading to hyponatremia, hypertension, and internal derangement. Even the water prescriptions can decrease cyst growth in polycystic kidney disease. How does it come? Because if you allow the person to drink water, this will decrease the stimulation for antidiuretic hormone release, and antidiuretic hormone is a stimulus for cyst growth. So if you allow the patient to have urine isocyanuric, the plasma isocyanuric urine means that the osmolarity of urine is 285, like the plasma. This will decrease the release of antidiuretic hormone and lead to decreasing the expansion of the cyst. And this is very simple by applying this equation. And if I suppose that the patient osmolarity is 800, I'll divide by 285 and minus the volume the patient brought from the urine. So the net result, I should add it to the patient to drink to decrease the osmolarity from 800 to 285. And this study, they succeeded in decreasing the osmolarity to the targeted value. Regarding the type of juice to be drunk, the orange juice or lemonade is there any difference between orange and lemonade? This study, crossover study, showed that the orange juice increases the alkali absorption and increases the urine pH, and this is contrary to the lemonade. So although they have citrus, they are citrus fruits, but they behave differently regarding the alkalization of urine. So if the patient had calcium oxalated stone, I may encourage orange juice. And if the type of stone is calcium phosphate, I may encourage lemonade use. This is a meta-analysis of all the studies done on the fluid. And as you see, they recommend just high fluid intake and decrease risk of recurrent nephrolithiasis. And the most important is drinking water. Thiazide, it is an important step in the management of calcium stone because thiazide decreases the calcium excretion in urine, so it decreases the likelihood of development of stone, and this is contrary to the furosemide, because furosemide is a diuretic but increases calcium excretion, and it's not recommended to decrease stone formation. So thiazide is good drug. A very important point is we should be aware of all the drugs taken by the patient, so we should ask the patient about the drug history, and we should avoid or decrease the use of these drugs in patients with stone formations. Low diuretics, as I mentioned before, because it will increase calcium excretion. Vitamin D, but if the patient has a deficiency of vitamin D, I can prescribe vitamin D, but with observation of 24-hour urinary calcium excretion. Corticosteroid, calcium supplement, I shouldn't restrict calcium, but it's better to not give calcium supplementation except it is indicated. Cyclophilin, acetazolamide, amphotericin B. Many diets, including oxalates, like all these in this table, green beans, beets, celery, leeks, cacao, chocolate, black tea, etc. And other foods contain purines. It is not suitable for patients with hyperuricemia, like the meats and fish. Another important point, the melamine exposure. It is like urea, it's a nitrogenous material. And until September 2008, more than 50,000 Chinese children younger than 3 years have been described with this stone, so I should be careful about the milk powders. Another important study showed that DASH is an abbreviation of diet approach to stop hypertension. The main components of this style of diet is to restrict proteins, restrict salt, enhance fruits and vegetables and milk products, and decreasing alcohol intake. And this is a well-known type of diet in decreasing hypertension or non-pharmacological treatment for hypertension, and it was proved to be beneficial in patients with stone formations. Also, the oxalate intake and the risk for nephrolithiasis discussed in this paper. Regarding obesity, we don't like obesity, and we should fight against obesity because obesity increases the risk of stone formation, especially in females, as shown here, and especially in diabetic and hypertensive. Another important point in diabetics, the urine pH is the tendency of urine pH in diabetic is toward low urine pH, so increasing uric acid stones, and this is because increased excretion of acids in diabetics. And this is also is confronted with metabolic syndrome, obesity, and diabetes. There is increased risk of decreasing urinary pH, and we should take care of that. The next sector, I'll discuss some case scenarios and some examples and some questions. So this is one of the cases that was published last year. A 38-year-old woman was referred for metabolic evaluation for multiple kidney stones. Her clinical history was eventful until her first pregnancy 4 years previously, when she developed a malar rash with positive antinuclear antibodies. After delivery, she developed a profound muscle weakness, required urgent medical advice. She was found to have severe hypokalemia. It's a very important point to catch hypokalemia when you are dealing with a stone. So this is one of the most important statements said until now. With a serum potassium 2.1, elevated creatine kinase 5,000, and hemoglobin 7,000. So this is the data. The patient was hospitalized, and her condition slowly improved. And potassium supplementation, nephrology workup showed mild proteinuria between 0.3 to 1 gram per day. Normal kidney function, metabolic acidosis, another important point. So we have hypokalemia, and metabolic acidosis. And urinary alkalosis, if you have systemic metabolic acidosis with urinary alkalosis, both renal tubular acidosis as a diagnosis, and then reaching in your algorithm of investigation to the cause of this RTA, with potassium citrate supplementation, potassium level stabilized between 3.2 to 3.7. Serological testing showed positive antinuclear anti-Rho and antinuclear SSA Rho and anti-SSB La antibodies, and any antibody complement Shermer tests and salivary ultrasounds results were unremarkable. So the diagnosis is tubular interstitial nephritis because there is some proteinuria, tubular protein, and the collagen disease of undetermined nature. 4 years later, the patient came with recurrent UTI, intermittent joint pain, and renal colic, and the radiology revealed, CT revealed multiple stones. This white dotted, this is the stones, and here is stones with even nephrocalcinosis in the tissues. So this is a case of RTA, and the presence, if you do investigation for Sjogren syndrome and the clinical examination for Sjogren syndrome, and you find that the data is negative, you should follow the patient because you may find it positive later, and this is the case in this scenario. So this renal tubular acidosis related to Sjogren syndrome, and in Sjogren syndrome you may have renal tubular acidosis, interstitial nephritis, and even immunological disease. So the teaching point from this case is if you have hypercholoremic metabolic acidosis in hypokalemia, look at urinary potassium. If urinary potassium is below 15, you are dealing with case of diarrhea. If urinary potassium above 15, you are dealing with renal tubular acidosis. Look at urinary pH. If it is above 5.3, this is a distal type of RTA. If it is below or variable, it is proximal RTA. Another case, another interesting case that was published in NET Plus in 2010, a male patient born in 1990, first presented with a kidney stone when he was 10 years old, but the stone had passed spontaneously and no further testing was done at the time. At the age of 20, he presented with a second episode of renal colic, proteinuria, and microscopic hematuria were also noticed, for which he was referred to a nephrologist. On examination, he was a lean young man with normal height and stature. Height was 175 centimeter and weight was 59 kilogram. Systemic examination was unremarkable. Blood pressure 117/74, and the main derangement in the evaluation is higher creatinine 130 micromole, and the creatinine clearance is 62 milli per minute as estimated GFR by the MEDRD equations. Higher alkaline phosphatase, and the calcium is high in urine. So, and then the total protein, mild tubular proteinuria. So this is low molecular type proteinuria. So these all the defects in this case, and the radiology showed cortical cyst as here, as you see, and the nephrocalcinosis here, and the stone here. So this is a cortical cyst. Renal biopsy was normal, and after the acute renal colic, transurethral stone extraction was performed. A stone analysis showed a stone consisting of calcium phosphate and calcium oxalate. The family history was negative for renal diseases or renal colic. The patient had no siblings, and the ultrasound of both parents showed normal morphology in of their kidneys without cysts, but one asymptomatic nephrolithiasis was found in the father. So if you look, you should put yourself in this roadmap. Are you dealing with hyperuricosuric with hypercalcemia or hyperphosphaturia, or you are dealing with hypercalciuria without hypercalcemia? In this case, we are dealing with hypercalcemia without hypercalciuria without hypercalcemia. So we are dealing with this sector of the cases. According to the situation in this case, we don't have metabolic acidosis, so we don't have renal tubular acidosis. We don't have the criteria for all these diseases, Bartter syndrome, etc. The only fitting criteria is Dentist disease, because Dentist disease is a hereditary tubulopathy in the large majority of cases caused by a mutation in the LCN5 gene. It's characterized by X-linked inheritance. So here in the evolution of the father, there was a stone, low molecular weight proteinuria, hypercalciuria, nephrocalcinosis, and or nephrolithiasis and progressive renal failure. Dentist disease can present with multiple renal cysts and may be considered in the differential diagnosis of cystic renal disease. Another case report, a 48-year-old that was published 2 years ago, a 48-year-old Caucasian man with renal failure and a history of recurrent renal staghorn lithiasis on both sides, revealed by sonography at the age of 17. No familial cause of lithiasis were reported, and recurrence occurred every 2 to 3 years, always on the right side. Crystal analysis was not performed, and this is one of the defects. In this case, we should respect stone analysis. The extracorporeal shock wave lithotripsy was done at the age of 20, and his serum creatinine worsened with time, 2 milligram per deciliter at 30 years to 4.5 at age of 41 years, and hemodialysis was started at the age of 42. Renal transplantation was his most immediate course, but after 2 weeks he had renal colic and creatinine rose, and the biopsy revealed the presence of these crystals, so he passed stone to exhalators, and renal stones by analytical X-ray diffraction software showed that they were composed of 2 and 8 dihydroxyadenine, suggesting adenine phosphoribosyl transferase deficiency. Adenine phosphoribosyl transferase is an enzyme that transfer adenine into AMP. In the absence of this enzyme, the adenine is converted to 2 and 8 dihydroxyadenine, leading to stone formation. Allopurinol therapy was started with high fluid intake and low protein diet with marked improvement. This enzyme activity was measured in lysate in intact erythrocyte for patients in his brother. Teaching point extrapolated from this case, analysis of renal stone is important and should be sought, especially in recurrent stone formation, provided adenine phosphoribosyl transferase deficiency is recognized early. Renal failure can be prevented, arrested, or reversed by treatment with allopurinol, which inhibit xanthine oxidase, thus reducing 2 and 8 dihydroadenine formation that's metabolized by this xanthine oxidase. Another important point is if there is familial history, because there is familial hypomagnesemia with hypercalciuria, nephrocalcinosis, and stone formation syndrome, and there are 2 types, colludine 19 and colludine 16. Colludine 19 is more dangerous, associated with renal failure and CKD and with renal problem. The question now, if the person has some stone, does the stone preclude donation? By another way, living donor with suspected renal stone, we consider them as potential donor? The answer, as dictated from the Amsterdam Forum, an asymptomatic potential donor with history of a single stone may be suitable for kidney donation if no hypercalciuria, no hyperuricemia, no metabolic acidosis, no cystinuria or hyperoxaluria, no urine tract infection, no multiple stone detected by CT. Asymptomatic potential donor with current single stone may be suitable if the donor meets the criteria shown previously for single stone formers and the current stone is below 1.5 centimeter in size or potentially removable during transplant. A stone former should not donate if there is nephrocalcinosis in X-ray, if the stones are bilateral, stone recurrence while on appropriate treatment, failed therapy, stone therapy difficult to prevent with high recurrence, stone associated with inherited disorder or systemic disorders. Another point, if you have a person who wants to donate according to the presence of symptoms plus the stone, you can predict if the person is symptomatic, you can predict higher number and higher size of stone. Another case report showing the patient with morbid obesity that was subjected to bariatric surgery. In these scenarios, we should exhaust ourselves to decrease the chance of oxalosis, because in this situation with malabsorption and decreasing calcium intake, there is a chance for absorption of oxalate leading to oxalate stones. And as you see here, examination of the specimen under polarized light showed polarization of the oxalate crystals. Even in pancreatitis, this is also may lead to malabsorption and the oxalate deposition. While you are dealing with huge tumors like lymphoma or leukemia, you should be cautious, because tumor lysis syndrome may occur spontaneously even without chemotherapy, and it should be put in mind and treated efficiently. Allopurinol, it's important to decrease the chance of uric acid stones, but we should take care and follow the patient regarding the development of rash. Sometimes the rash may be fatal, as it's in this photo, it is toxic epidermal necrolysis, and if the patient is intolerant to allopurinol, we can prescribe febuxostate, another important therapy for hyperuricemia. Calculus stone may occur, and it's not common like kidney and ureter, and this is the case of elderly patient with dysuria and oliguria, and the investigation revealed the big calculus stone with hydronephrosis, and this is a calculus stone. Another important point to be tackled and searched in the history is the presence of eating disorders. So if you are dealing with a case like this is a 33-year-old black woman is admitted with right flank pain radiating to the groin and associated with gross hematuria. Her history is noteworthy. For one previous episode of nephrolithiasis 6 months before, the patient works as a fashion model, and when the patient is working fashion model, you should suspect anorexia nervosa, suspect eating disorders, bulimia, and as such, she has always been concerned about her body weight. She admits to use diuretics in the past, but denies recent use of diuretics, laxative, or vomiting. Physical examination shows a blood pressure 122/78, no orthostatic change. The remainder of the examination is normal. Creatinine is 1.1, and as you see, sodium, potassium, chloride, bicarb, and urinary electrolytes, sodium 10, potassium 15, chloride 80. So based on these situations, and the stone analysis revealed ammonium rates. So what is the cause of stone formation? Is it sebaceous vomiting, or laxative abuse, Bartter syndrome, Sjogren syndrome, or diuretic abuse? Based on urine analysis and stone analysis, it is laxative abuse, because laxative abuse can lead to decreasing the intracellular pH, and decreasing intracellular pH lead to decreased urine citrate formation and increased ammonia, so ammonia is increased, and because of decreasing extracellular volume because of diarrhea and the loss of potassium, there is decrease in urine sodium and leading at the end to ammonium urate stone formation. And these are 2 articles that was published this month under laxative abuse, eating disorder, and kidney stones, and the other one anorexia nervosa and the kidney stones, so we should take care of that. Regarding primary hyperoxaluria, it is another entity, autosomal recessive disease, may be characterized by multi-system affection, kidney, bone, eye, arteries, myocardium, thyroid. So it is a systemic disease due to defect in this enzyme. And these are the entity perspective in evaluation. They recommend considering a diagnosis primary hyperoxaluria in any child with a first kidney stone, and in an adult with recurrent stone formation. They recommend considering diagnosis of primary hyperoxaluria in any subject with nephrocalcinosis, particularly when associated with decreased GFR. We recommend searching for pH in the presence of oxalate crystal, calcium oxalate monohydrates. We recommend screening relatives of index cases. We don't recommend screening in the general population. So these are the NDT perspective European guidelines. And the biochemical and the enzyme assessment include recommending measuring 24-hour oxalate, creatinine, and the glycolate in any patient with possible diagnosis of primary hyperoxaluria type 1, and the preserved renal function as a first-line evaluation. They recommend measuring plasma oxalate in CKD patients. They recommended measurement of AGT enzyme activity if generic testing is inclusive. And if you look in this data, although the transplantation after 2000 for primary hyperoxaluria is improving, but still the outcome for the patient with oxalosis is far below the standard control. And here the best treatment is liver and kidney transplantation for these patients. Another important point is that, as I mentioned in the beginning, we should respect the urine pH. Here, if you are dealing with calcium phosphate, you find higher saturation with increasing urine pH. So in this scenario, at least we don't prescribe alkalis. As you see here in another scenario, using citrate in the medullary spongy kidney decreases the chance of diseases. Using histamine in treatment of nephrogenic cystinosis is very important and crucial to start from the early life to decrease end-stage kidney diabetes, hypothyroidism, and even death. Another interesting point is the use of calcium sensing receptors and calcium stone formation, and this is a concept to decrease calcium phosphate stone formation, because these calcium sensing receptor drugs can lead to the closure of the channels of water, so it decreases the water, increases water diuresis and decreases water absorption. And the second point, it works with hydrogen ATPase pump, so increase urine hydrogen and decreasing urine pH. So if you decrease urine pH and increase the urine, we will decrease the calcium phosphate stones. Again, lastly, the point regarding vitamin D. If there is any deficiency in vitamin D, we can give it a lab, provide that we follow 24 hours of urine. And if you see here, there is no difference between the patients either with vitamin D or not regarding the calciuria. So if there is indication for calcium, for vitamin D in patients with stone formation, we should give them this vitamin D, provide that we follow 24-hour calcium excretion. And thank you for attention.